A warm welcome to one and all. This is Dr. Sunil Manuel, Associate Professor from the Department of Orthopedics, and today we'll do a session on acute osteomyelitis. Before we do a session on acute osteomyelitis, I would feel it's important for a student to understand the spectrum of musculoskeletal infections, or in other words, the spectrum of infections that an orthopedic surgeon would be dealing with. So when you take the spectrum of infections, normally for an orthopedic surgeon, we are looking at the spectrum of infections that can occur in the bone, that is in the limb, as well as in the spine. So these are the things that we are interested. Now, the first and the foremost thing that an orthopedician would be interested in would be infection, obviously, of the bones. So these bone infections are called osteomyelitis. Sometimes the bone may not be infected, but the joint, which is nothing but the articulation between the bones, may be infected. And in which case, we would call it arthritis, and this kind of arthritis would be an infective arthritis. Sometimes we can have the muscles that are infected. So when muscles are infected, the condition is called pyomyositis. Rarely, we have some protective structures that protect the musculotendinous units, especially from friction. So these are bursae, and predominantly most of the bursae have a lining of synovium. And so sometimes the bursae themselves may be infected, in which case we call it bursitis. And sometimes we can have a deadly infection which is swiftly progressing of the skin, the subcutaneous tissue, and the deep fascia. That would be called a necrotizing fasciitis. So this is the spectrum of infections that an orthopedic surgeon would be treating, both in the upper limb as well as in the lower limb, as well as with regards to the spine. Now, what is osteomyelitis? So if you break down this word, that is osteomyelitis, there are three subcomponents in this word. One, we have this word called osteon, which actually means bone. Secondly, we have this word myelo, which means bone marrow. The word myelo also in some other instances refers to the spinal cord, but in this scenario, it would be myelo represents the bone marrow, and itis, obviously meaning inflammation. So basically, osteomyelitis, theoretically, as the word suggests, means an inflammation of the bone and the bone marrow. So that is what it means. So when it means inflammation of the bone and bone marrow, we have to be very careful to include not just the cortex, the bony cortex, but also the medullary cavity, and most importantly, we have to understand that even the periosteum, which is the covering of the bone, is also caught up in the inflammation. However, normally we see that the infection of the bone and bone marrow is the most common reason for inflammation of the bone and bone marrow. Therefore, the word osteomyelitis, though technically it means inflammation, it's almost in day-to-day practice used interchangeably with infection of the bone and bone marrow. So coming to the classification of osteomyelitis. So when I was a student, we were taught about three types of osteomyelitis, which was acute osteomyelitis, subacute osteomyelitis, and chronic osteomyelitis. We were also taught that acute osteomyelitis is an infection that usually occurs within 3 weeks. Subacute osteomyelitis is an infection that occurs between 3 and 6 weeks. And chronic osteomyelitis is an infection that occurs after 6 weeks. So we had a strict time range for the classification of osteomyelitis. However, now things have changed quite a lot, and the whole classification of osteomyelitis is now based on the clinical scenario in which the child or the adult presents to the clinician. Also, we now have a new entity called the chronic recurrent multifocal osteomyelitis. So previously, this chronic recurrent multifocal osteomyelitis was subclassified under chronic osteomyelitis. Now it is a separate classification by itself. So what I want you to understand is a classification based on time. That is what I told, 3 weeks, between 3 to 6 weeks, 6 weeks and above, is now slowly being replaced by a classification based on pathogenesis. So I would spend a little time to make you understand the broad pathogenesis of the first three types, that is the acute osteomyelitis, the subacute osteomyelitis, and the chronic osteomyelitis. So what is this differentiation based on pathogenesis? So this differentiation is basically trying to tell you that the acute osteomyelitis occurs in a person who basically had a perfectly normal bone. And the other thing is, as the word suggests, it's an acute condition. And thirdly, the body is standing helpless against this acute osteomyelitis. So it's a sudden acute infection of the bone with the body's defense system not very capable or not equipped to handle the infection. That the person or the patient requires help from the clinician in terms of prompt recognition of the condition and prompt management of the condition. If the clinician, which is me, as well as all of you who are training to be clinicians, are not able to pick up this thing at the appropriate time for the patient, then the patient is going to have a lot of problems. Now coming to subacute osteomyelitis. In subacute osteomyelitis, basically the body's immune response has now taken control of the infection. That is, the body's immune response has had sufficient time to recognize the infection and to prevent the infection from progressing. And therefore, the immune response of the body is trying to wall off the infection. Or in other words, the body's immune response as well as the infection have both achieved some kind of an equilibrium, and therefore it is there. The body is infected or the bone is infected, but the infection is not progressive. So how do you understand this? How do you understand that here that it is a subacute osteomyelitis? There are going to be clinical and radiological findings that suggest that the body's immune response is doing something to fight against this osteomyelitis. And finally, coming to chronic osteomyelitis. So in chronic osteomyelitis, the infection has taken so much control over the body that the body is not able to fight it anymore. And what I want you to understand is, a bone, if you take the structure of the bone is basically a structure that is heavily dependent on the surrounding soft tissue. So what is the surrounding soft tissue? The surrounding soft tissue includes technically even the periosteum. The periosteum is also the part of the surrounding soft tissue, the muscles, and the vascularity that the bone receives from outside. If the bone is stripped of the periosteum, if the bone is stripped of the muscle attachments, and if the bone is deprived of the vascularity, then the bone is quite defenseless and the bone is as good as dead. So in chronic osteomyelitis, not just the bone is infected, but also the periosteum and the surrounding soft tissue sleeve, which is actually nourishing the bone, is also infected. So in acute osteomyelitis, you don't have that problem. In acute osteomyelitis, only the bone is infected. The surrounding soft tissue sleeve is highly vascular and trying to mount an immune response, but it is not sufficient. But in chronic osteomyelitis, what happens is not just the bone is infected, the bone is killed, the bone is necrosed, and it's also surrounded by unhealthy soft tissue sleeve. So that is the crux of chronic osteomyelitis. And therefore, when I was a student, there used to be a saying that said, once an osteomyelitis, always an osteomyelitis. Things are definitely changing now. These days, we have methods to eradicate a chronic osteomyelitis. But however, it is quite difficult to eradicate a chronic osteomyelitis from the body, simply because the surrounding soft tissue sleeve is also infected. So getting rid of the bone is not a big problem. We can get rid of the bone, but eradicating infection from the soft tissue sleeve, nourishing the soft tissue sleeve, and giving good vascularity to the infected bone to bring in the healing process is a big challenge. And the other thing is, chronic osteomyelitis seems to be, from the books that we read, seems to be a scourge of the developing countries. Maybe it's not so commonly seen in the developed countries. So this is what I meant when I said that a classification based on mere time that is to say 3 weeks, 6 weeks, 9 weeks. Those things are out now, and the classification is now being replaced by a classification based on pathogenesis. And I'm sure now all of you can tell the difference between an acute osteomyelitis and a subacute osteomyelitis and a chronic osteomyelitis from the way that I mentioned the pathogenesis to you. Now let us come back to our primary today's class, that is the acute osteomyelitis. And the first thing about the acute osteomyelitis is the dramatic presentation. So I mentioned to you about the dramatic presentation of an acute osteomyelitis. Basically, the age group is usually children, and it is predominantly seen in children in the first decade of life. So why it is seen in children, I will explain it a little later. The other important thing is, as I mentioned, the presentation. So basically what you have is, you have a relatively normal child, a healthy child, suddenly presenting with an infection within the bone. So that is how the presentation is going to be. And because it's an acute infection, it is going to behave like any other acute infection in the body, like a pneumonia or like a meningitis, in terms of the child having high grade fever, dehydration, and the child looking very sick and lethargic. Coming to the etiology, the most common reason for acute osteomyelitis is the hematogenous spread. So the question is, how did the infection come into the bone? Now, the infection basically came into the bone through the bloodstream. So that is what we need to understand. Hematogenous infection is so very common that acute osteomyelitis is also referred to as acute hematogenous osteomyelitis. So it also means that more than 95% of cases of acute osteomyelitis is because of spread through the bloodstream. So what basically happens is that children tend to normally suffer from infections in their bodies, like throat infection, tonsillitis, pharyngitis, sometimes ear infections, sometimes skin infections, and basically these infections tend to send in bacteremia, loads of bacteria into the bloodstream. So much so, it's even postulated that a mere brushing of the teeth, and especially in children with caries, a mere brushing of the teeth itself sends bacteria into the bloodstream. Now basically what happens is, this bacteria, as it enters the bloodstream, immediately the immune response of the child will take control of the infection and will try to eliminate the infection as much as possible. But occasionally there may be a possibility where the bacteria can go into the bone and lodge in the bone, causing an acute osteomyelitis. As a corollary, what we all need to understand is, whenever we have children who are having foci of infection in the body, like a dental caries or a chronic throat infection which is recurrently coming on again and again, or an ear infection or a pyoderma, it's very, very important that we need to promptly treat the child and eradicate the infection from the body, because children are at high risk for acute hematogenous osteomyelitis. The other thing is, sometimes acute osteomyelitis can also occur due to contiguous spread, that is due to spread from other parts of the nearby parts of the body. A common reason for acute osteomyelitis due to contiguous spread would again be limb infection. So sometimes the children do have boils, conditions like necrotizing fasciitis or cellulitis, from where the infection can slowly seep into the bone and can infect the bone. Another way of contiguous spread is where there is a septic arthritis or an infection of the joint, and if the infection is not taken care of, then the infection can now slowly spread into the bone. Though those possibilities of contiguous spread is extremely rare. Again, as a rule of thumb, it should be understood by every medical student that when a child presents with a limb infection, even if it's a small boil or even if it's a small abscess, the child should be treated on the protocols of acute osteomyelitis. So very often we see cases in which the children present with boils, especially because of pyoderma, and these boils tend to progress into an abscess within the arm or the forearm or the leg or the thigh, and the child is typically taken to a pediatric surgeon, or the child is taken to a general surgeon who will drain out the pus just like they would drain out any abscess. However, if this drainage is not adequately done, then the child can progress into acute osteomyelitis. So therefore, the pearl that you need to understand here is any limb infection, especially in pediatric age group, should be treated on the protocols of how we treat an acute osteomyelitis, or it should be treated in consultation with an orthopedic surgeon. That is the important thing that you should know. And lastly, acute osteomyelitis can also occur because of direct inoculation of infective material into the bone. So this would happen sometimes after penetrating injury or sometimes after surgeries involving the bone, especially when we use implants on the bone. So there is a lot of drilling and putting implants that we do into the bones, and if we don't take care to maintain the sterility, then the person, this could be a child or an adult, they can have an acute osteomyelitis due to a direct inoculation. Similarly, when we have penetrating injuries into the limb, all penetrating injuries into the limb have to be treated by exploration of the wound to see whether the penetrating wound is reaching up to the bone. Very often what happens is we see small sized wounds which look smaller from outside, but as we take them to the theater, we notice that when we extend the wound, we realize that the penetrating object, whatever it was, whether it's a knife or a sharp instrument, has gone all the way right down to bone, and sometimes even caused a fracture of the bone. So in these cases, what basically happens is the tip of this penetrating instrument could be having infective organisms, and these organisms can go and lodge in the periosteum or in the cortex of the bone, thereby inciting an acute osteomyelitis. Of course, I would say that contiguous spread and direct inoculation are quite rare conditions, and therefore for all practical purposes, especially in children, because they are the most common age group for acute osteomyelitis, we will take hematogenous mode of transmission or hematogenous osteomyelitis as the most common cause of acute osteomyelitis. Now, what kind of bones are involved in acute osteomyelitis? Again, we see that 3/4 of the time the long tubular bones are more involved as compared to 1/4 of the time when the other bones are involved. So what do I mean by the long tubular bones? I basically mean the femur, the tibia, the humerus, fibula, radius and ulna. So these bones account for nearly 75% of the acute osteomyelitis, and only 25% of the acute osteomyelitis we see in the other bones. So these are flat bones like the pelvis, the scapula, and of course the spine. Now, why again long tubular bones? I'll explain to you. So the relation between the long tubular bones and children, and the fact that acute osteomyelitis is more commonly seen in long bones in the metaphysis of the bone, is related to the same pathogenesis. When I come to the pathogenesis, you will understand why this is more common in children, this is why it is more common in the metaphysis, and why it is more common in the long tubular bones. Now, coming to the organism, which is the organism that is causing acute osteomyelitis? So the most common organism across any age group is the Staphylococcus aureus. So that is the most common organism. However, in neonates, sometimes you may get group B streptococci also. How is this possible? This is possible because neonates very often suffer from something called neonatal sepsis, where there is a relationship to the mother's genital flora in the causation of neonatal sepsis. And therefore group B streptococci is also part of the same maternal genital flora, and therefore neonates you can get a higher incidence of group B streptococci. But this does not mean that that is the most common organism in neonates. In all age groups, I want you to understand that Staphylococcus aureus is the most common organism. It is just that in neonates, sometimes you may get a higher incidence of group B streptococci. And what about infants? Again, the same logic applies. In infants, you may get a higher incidence or a higher number of Haemophilus influenza. However, Staphylococcus aureus is still the most common organism in infants. Now there is a peculiar condition called sickle cell disease, and in this disease, for some reason, peculiarly, the Salmonella species is seen to be a causative organism for acute osteomyelitis. Now, what is the importance of knowing that Staphylococcus aureus is the most common organism? The importance is whenever we receive a child or a patient with acute osteomyelitis, our antibiotic that we give should cover Staphylococcus aureus. So that is the dictum, that is the empirical treatment. Now coming to the understanding of the pathogenesis of acute osteomyelitis. So when you understand the pathogenesis of acute osteomyelitis, then obviously you're going to understand why it is more common in children, why it is more common in the long tubular bones, and why it is more common in the metaphysis. So when you take a child, you will notice unfused skeleton. So in between you have the growth plate. So beyond the growth plate, the bone that you have beyond the growth plate is called the epiphysis, and at the growth plate it is called the physis, and the bone that is in contact with the growth plate is called the metaphysis, and then obviously you have the diaphysis on either side. So when you take the vascular supply of the metaphysis, you will notice a few peculiarity. So the first peculiarity is that when you see this metaphyseal blood supply, they are having the sinusoidal pattern of arrangement. So the arteriole as well as the venules have a sinusoidal pattern of arrangement. This sinusoidal pattern of arrangement, as it goes towards the growth plate becomes avascular, or it becomes a watershed line, which means the epiphyseal blood supply does not come in contact with the metaphyseal blood supply in a child with an unfused skeleton. So the growth plate or the cartilage acts as a barrier. So at this stage, as the metaphyseal arterial supply comes up and comes towards the physis, it has to immediately take a 360-degree turn, causing a hairpin bends. So these bends are called the hairpin bends. And at these hairpin bends, classically what we see sluggishness of the blood flow. So this sluggishness of the blood flow is one reason why there is increased incidence of acute osteomyelitis in the metaphysis. The second reason is these metaphyseal vessels basically have got leaky cells, and these leaky cells tend to leak out the bacteria. If the blood was flowing at a normal speed, then there would have been very less chance for the bacteria to leak out of these blood vessels. But since there is sluggishness of the blood flow, there is a higher incidence of bacteria leaking out into the extravascular space. And in the extravascular space, what do we have? We have the nice bone marrow, which is a very ideal culture medium for bacteria. So that is the second reason. And the third thing is, if you take the epiphysis, the metaphysis and the diaphysis, the phagocytic activity in normal circumstances is least in the metaphyseal area. So why do you need this phagocytic activity? The phagocytic activity is the one that actually defends the body against infections. So the defense to infections is least. It is not that it is not there, but it is the least in the metaphysis. So these three factors put together make the metaphysis a high risk area for infection in the long bone. So obviously now it explains to you why acute osteomyelitis is more common in children, because they have unfused skeleton leading to sinusoidal pattern of blood vessels, and why it is more common in the metaphysis because of the hairpin bends and the reduced phagocytic activity and the gaps in the endothelium and the sluggishness of the blood flow, and also why they are present more common in the long tubular bones, because only the long tubular bones have this differentiation between the epiphysis, physis, metaphysis and the diaphysis. Now coming to the pathogenesis of acute hematogenous osteomyelitis. Now you understood this whole story of sluggishness of blood flow and why the metaphysis is involved. Now there is a different story to tell. So this is a sad story of how one factor leads to another factor and becomes a cascading process in the pathogenesis of this very devastating infection. So I expect all my students to know this story, and this story is called the story of the pathogenesis of acute hematogenous osteomyelitis. So I told you to begin with, so when you go back to the previous slide, you realize that there is leaking of bacteria into the metaphysis due to the sluggishness. There is also poor phagocytic activity in the metaphysis, and therefore what do you expect? The bacteria will start multiplying. So when the bacteria starts multiplying, how much ever less the phagocytic activity is there in the metaphysis also, the body will immediately sense that there is an infection in the metaphysis, and therefore the phagocytic cells from the other parts of the body will be quickly mobilized to come and tackle this infection. So once the phagocytes reach that area, then immediately the neutrophils, the macrophages, all of them will start fighting the bacteria to bring the infection under control. And as a result of the fight between the bacteria and the phagocyte cells, we will end up with pus. So what is pus? Pus is nothing but the byproduct of an inflammatory response between the phagocytic activity of the body or the immune system of the body and a pathogen, which would be in this case a bacteria. So there is a formation of pus in that area. So now we slowly are seeing that the metaphysis is getting filled with pus. Obviously this pus is not going to go into the epiphysis because we have the solid cartilage here, and it's also avascular, so the cartilage will actually resist infection from going into the epiphysis. Also the infection will not go into the diaphysis. However, the pus anywhere in the body wants to get out of the body as early as possible, and therefore the pressure builds up in the metaphysis, and then there are holes in the cortex due to the Haversian system as well as due to the Volkmann's system, and through these holes the pus will slowly track through the cortex and come and lie under the periosteum. However, at this stage we have the next problem. So if the periosteum also had torn and allowed the pus to come out, the problem would have been solved to a very, very good extent. Unfortunately, in children, the periosteum is thick and the periosteum is unyielding because there is fibrous tissue that is there in the periosteum. The periosteum says, yes, maybe the bone let the pus come out through the holes in the bone. However, the periosteum says, I am not going to let this pus get out of the bone. And therefore, what happens is as the pressure of the pus starts building up, the periosteum starts getting lifted off the bone. Now, this periosteum is supposed to be the lifeblood of the bone. It's supposed to be the life jacket of the bone. The vascularity to the cortical bone comes through the periosteum. Of course, there is an endosteal circulation, but but there is a significant contribution from the periosteal circulation also. So whenever the periosteum is stripped from the bone, then the underlying cortex tends to become avascular. And here what is happening? The periosteum, in its adamance not to allow the abscess to get out, is actually getting elevated, and as it is getting elevated, the infection tends to track distally or proximally along the cortex, and therefore a huge area of the cortex is now slowly starting to get devascularized because of lifting of the periosteum. And this, mind you, is the saddest part of the story. So this, if it is not recognized in time by the patient presenting promptly to the hospital, the clinician recognizing this problem and going in and releasing the pus from the periosteum, if this is not done in time, then the bone is going to suffer irreversible damage. And this is what makes acute osteomyelitis nearly a medical emergency. And therefore, as a student, if you can understand this concept of decompressing or evacuating the pus from underneath the periosteum and from inside the metaphysis, so you will not understand the emergency or the importance of this situation unless you understand the pathogenesis. Now coming to some anatomical peculiarities in some areas. So now this is a proximal femur. So basically what you're seeing is this is a proximal femur of a newborn, and in a proximal femur of a newborn, the entire proximal femur is cartilaginous. And because the entire proximal femur is cartilaginous, the metaphyseal blood vessels tend to communicate with the epiphyseal blood vessel. And when there is a communication between the metaphyseal blood vessels and the epiphyseal blood vessel, any infection in the metaphysis is actually going to get into the epiphysis. So a metaphyseal osteomyelitis will quickly become a metaphyseal and epiphyseal osteomyelitis. So this is what happens in a newborn up till the child comes to around 18 months of age. At 18 months of age, we suddenly see that there is a differentiation into the physeal plate, and the epiphyseal blood vessel circulation is different and the metaphyseal blood circulation is different. As far as the metaphysis of the proximal femur as well as the proximal humerus, there is an anatomical peculiarity. Up to 18 months of age, a metaphyseal infection in the proximal femur or the proximal humerus will quickly turn into a metaphyseal as well as epiphyseal infection because of the continuity of the metaphyseal blood vessels into the epiphysis. After 18 months of age, with the appearance of the epiphysis of the femoral head as well as the epiphysis of the humeral head, however, now you have a different problem. Now here the problem is, if you notice, the joint capsule incorporates a part of the metaphysis, and therefore in this age group, that is after 18 months of age, the proximal femur infection or the proximal humerus infection, which is contained in the metaphysis, can now start leaking out and go into the joint and cause a septic arthritis. So this is the anatomical peculiarity. In a child below 18 months of age, the infection eats up the metaphysis as well as the epiphysis of the proximal femur and the proximal humerus. But after 18 months of age, the infection does not involve the epiphysis, but the infection can leak into the joint because the capsule incorporates a part of the metaphysis and then goes straight into the joint and cause a septic arthritis or an infection of the hip joint or of the shoulder joint. So these are the anatomical peculiarities that you see in the proximal femur as well as the proximal humerus. Now coming to the presentation. So already I have told you that the child is going to present to you with fever, irritability, the child is going to look very dehydrated and the child is going to look very sick. So basically the child is going to present like any other child presents with an acute infection, like an acute pneumonia or a meningitis or an abscess in the body. So that will be the presentation. Additionally, the child will also have local pain in the area that is involved, and there is going to be swelling of that area. Additionally, the child is also going to have inability to move the limb. So the child would find it very painful to even move the limb. The child will not allow the parents or the clinician to touch the limb, as well as the child will refuse to bear weight. If it's already a walking child, the child is going to refuse to bear weight. In neonates, it's very, very difficult to pick up these signs. The only thing that we can pick up is reduced movement in the limb. So whenever we see a reduced movement in any one of the four limbs, then immediately the clinician is going to carefully examine around the joints to see whether there is any soft tissue swelling. Now, one peculiarity is that even studies have proved that in 1/3 of the children there is a history of trauma. So how trauma causes infection in the bone, nobody knows. But then it is very clearly proved that up to 1/3 of children have had some kind of a trauma to that limb just a few days before the onset of acute osteomyelitis. So one reason that is postulated is that trauma may lead to the parents or the caregivers massaging that part of the limb, which would have caused an infection in the bone. But since we feel that acute osteomyelitis is a hematogenous infection that has come through the bloodstream, it is very improbable that massaging of a particular part of the body can cause acute osteomyelitis. The other postulation that is put is that acute that is trauma itself may sometimes reduce the immune response or the local immune response in a particular part of the body. And therefore, this part of the body which is traumatized by virtue of having a poor immune response may have been at higher susceptibility to acute osteomyelitis. So that is the second postulation. Now coming to the blood picture. Now basically, just like in any other condition with an acute presentation of a bacterial infection, we have neutrophilic leukocytosis. The blood picture will show a high count of WBCs with an increased percentage of neutrophils. So what is the role of ESR and what is the role of C-reactive protein in the treatment or in the management of acute osteomyelitis? So the first thing that we need to understand is ESR starts rising only at 36 to 72 hours. So it takes 1.5 to 3 days for ESR to even start rising. And ESR peaks at 7 days and then ESR falls by the end of 6 weeks. As coming to C-reactive protein, we would see that the C-reactive protein will start rising from 6 hours into the infection. So the very first day there will be a rise of C-reactive protein. This is going to peak at 36 hours and it is going to fall back to normal when effectively treated by 7 days. So what does it mean? It means the early response and the early fall will be seen in C-reactive protein. So C-reactive protein is used to guide the treatment protocol. So that is because it's the early riser. If we wait for ESR to rise, it may take much longer. However, ESR also has got its own importance. Basically, the ESR falling at 6 weeks would help us to decide the end point of treatment. That is, at 6 weeks, if the ESR is still not come back to normal, then the clinician, based on other clinical parameters, would or may consider prolonging the antibiotic course. So that is the concept between ESR and C-reactive protein. As long as the patient is in the hospital, inpatient treatment, to decide the response to treatment, to see whether the response to the treatment, whatever we are giving, is effective, we need to go by the C-reactive protein. Now coming to interleukin 6 recently has been proposed as a much superior as compared to the C-reactive protein. However, as things stand now, it's pretty expensive and it cannot be done routinely for all children because of the very, very prohibitive high cost. Coming to the microbiological studies. So I told you that acute osteomyelitis is a hematogenous infection. So where do you expect to see the organisms? The organisms are going to be there in the blood. So whenever a patient with acute osteomyelitis presents to us, before starting the first dose of antibiotics, we always send a blood culture. And in a very high percentage of cases, your blood culture will come positive and it is going to grow the same organism which you are eventually going to find in the pus that you take out from the area. Now what about pus culture? Pus will be obtained only when you take up the child for the surgical evacuation. Sometimes we may decide not to take up the child for surgical evacuation. So the reasons for that I will tell you later. In such cases, we can even use an ultrasound and we can have an ultrasound guided pus aspiration where we are using the ultrasound to guide us to get to the subperiosteal abscess and aspirate the pus. Sometimes with the help of the ultrasound, we can even go down to the metaphysis also, but to penetrate the cortex, we will need a bone marrow aspiration needle. So that is how pus is basically obtained for the pus culture. Having said that, I would still emphasize that the blood culture is a very readily available and superior modality to pick up the infection. So what is the role of plain X-rays? To make a diagnosis of acute osteomyelitis, a plain X-ray is not required because a plain X-ray per se will not show any changes in a case of acute osteomyelitis. It may show a little bit of soft tissue edema just above the bone. Otherwise, the plain X-ray is not going to show us anything. However, the plain X-ray is of really good importance to rule out a presentation like an acute osteomyelitis, especially in other inflammatory conditions, and also to rule out traumatic conditions. So sometimes there may be a trauma with an associated fever. So a child will present with high grade fever along with a trauma. So in such conditions, it's important to use a plain X-ray to rule out a bone or a physial trauma. Now, one important thing that you should understand is whenever you see X-ray changes of infection on a plain X-ray, then that means the child is presenting to you only after 10 to 14 days, typically after 2 weeks. So for bone changes to appear on the X-ray, it takes up to 14 days after the onset of infection. Sometimes the parents may not have recognized that the child is having the infection, or in many circumstances we see that whenever the children are referred to these higher centers, the parents tend to typically not give us a very accurate history. So in these cases, an X-ray showing some changes in the bone definitely tells us this is a late presentation of acute osteomyelitis. That is because 30 to 50% of the bone's mineral density has to be lost for the plain X-ray to pick up the infection. So what is the rule of high resolution ultrasonography? A high resolution ultrasonography can be used to rule out other conditions that mimic an acute osteomyelitis. That is, sometimes cellulitis can mimic an acute osteomyelitis. Sometimes soft tissue abscess would be there, and this can mimic an acute osteomyelitis. Sometimes even a septic arthritis or a joint infection can look like a acute osteomyelitis, and very rarely even malignant bone tumors in children can present like an acute osteomyelitis. So a high resolution ultrasonography helps us step by step to rule out these conditions. The other use of high resolution ultrasonography is to guide the aspiration. So in this picture you will see that this thick area, this is the bone cortex, and this thin line or the wavy area that you are seeing, this is the periosteum. So here we are not supposed to actually normally see the periosteum so clearly, but here the periosteum is thick and edematous. So this edematous periosteum that is lifted up over the bone is clearly seen here, and here in this area you will notice that between the periosteum and the bone cortex there is a gap. So obviously there is a pus in that area. So using this window, basically what we are able to do is we are able to pass a needle and do an aspiration. Now what we need to understand is to get this successfully, this kind of an image, and to help you with the aspiration, you need a good operator. It is highly dependent on the ability of the radiologist. Now what about bone MRI? MRI is the investigation of choice for the diagnosis of acute osteomyelitis. So the MRI will pick up bone marrow edema as early as 6 hours into the infection. So here is this case where the plain X-ray hardly shows anything. We just can see that this area is a little edematous, the soft tissue is little edematous. However, in the MRI you clearly can see that the periosteum has been lifted and there is a seeping of pus along the bony cortex. So what you're seeing here is the fibula, and this area, this whitish structure, is nothing but the pus under the periosteum. So MRI helps to give us beautiful images like this. The other thing about MRI is MRI will also in multiple planes help us to clearly identify or clearly define the extent of the infection. So that is how the MRI will help. So clearly you are seeing that this area there is a metaphyseal infection because the signal intensity is different as compared to the epiphysis. Also you are clearly able to see that the periosteum is elevated, and what you are seeing on either side is nothing but the pus. The same thing in another view, this is how it would look. So this is an axial view and this is a coronal view. Now what you need to understand is therefore MRI is the investigation of choice because of high specificity and high sensitivity. Also the MRI will help us to make a very early diagnosis. So if the child is presented to us in time, and if we are quite early and if we are able to pick up this condition, and if we can get an MRI for this child very easily, very early, before even formation of pus, we will be able to pick up the infection. And the first sign on the MRI is a change in the bone marrow intensity or bone marrow edema. So that would be an early diagnosis. It's not a case in all cases, because by the time the child presents to us, especially to a tertiary center, it would be quite late. Now the problem with the MRI is obviously it's expensive. The other thing is it's not available in all centers, especially in the peripheral areas. So therefore not everybody would be able to access an MRI so readily. The other thing is, an MRI examination requires the child to be static or still within the MRI machine for at least 20 to 30 minutes. Now, what typically happens is, because these children are very sick, they tend to keep moving around and it would be very difficult to restrain them. So, normally, when we actually do an MRI for children, if we feel that the child is not cooperative in terms of not moving, then we would want to sedate a child. But sedating a child who's already sick, dehydrated, and is not safe, and therefore these are the drawbacks of an MRI. I would say, in the absence of MRI also, the child can be taken up for a decompression of the pus or removal of the pus if there is a high index of suspicion based on the clinical assessment. So if the clinical picture is clearly showing us, if the site of inflammation, the site of swelling is clearly showing us that suggestive of an acute osteomyelitis, we can take the parents into confidence and we can tell them that because of the lack of availability of MRI or because of the inability to do the MRI, we would want to take up the child for an emergency decompression of the pus. So if we take the parents into confidence and make the parents understand about the devastation that would cause by not doing this procedure, the parents would definitely readily give us the consent. So that is what I want to emphasize to you. However, taking this step would require a good amount of communication and documentation of the communication in the case sheet. Because let's say you take up the child for the surgery and it turns out that it is not acute osteomyelitis, definitely there will be a little bit of explanation that we will have to give to the parents, and at that time the parents should not feel that they were misguided or the whole problem was not clearly communicated to them. So this is where the communication skills of the doctor is going to be tested. Now coming to the treatment. So what do you do basically? The first initial treatment that you would want to provide is you want to rest the infected area or rest the limb. So what we are going to do is we are going to appropriately splint that limb. We don't want much movement in that limb. Obviously, resting is going to give rest to that part and help the part heal. The other reason is resting also would help the child to become less painful and more comfortable. And then pending culture report, what we are going to do is we are going to start broad spectrum antibiotics, taking good care that we include a good antibiotic against Staphylococcus aureus. Obviously, if at all we have an infant or a child, we are also going to cover for the other organisms. And the other thing is, the children are going to be very dehydrated and very sick looking, and therefore a lot of hydration and supportive measures are going to be initiated initially. So once we do these three things, that is splinting, antibiotics and hydration, and before I start the antibiotics, I mentioned to you clearly, do not forget to draw the blood for the blood culture. It's very, very important. It's because once you give antibiotics and then if you take the blood for blood culture, the culture can frequently come negative. Simultaneously, you are also doing all the imaging. So this imaging is extremely important because the imaging is helping us to rule out an abscess. So we want to know whether it is, first of all, whether it is acute osteomyelitis, point number one. Point number two is, if it is acute osteomyelitis, we want to know if the abscess has already formed. Now, mind you, it just takes not more than 24 hours for the abscess to form. So, how much ever early the child presents to us, it's going to be a very occasional child in which we are going to pick up the child before the abscess is formed. And why is this abscess formation important? The abscess formation is important because once the abscess is formed, it does not make much sense to continue antibiotic only treatment. We also need to go in surgically and drain out the abscess. But if at all in an occasional patient, we are able to pick up the infection very, very early before an abscess is formed, then we can continue to treat the child with antibiotics and look for the progress of the infection. Now, the guiding principles for the treatment of acute osteomyelitis are as follows. First thing is, only antibiotic treatment is effective before pus has formed. But if pus has formed, then pus requires surgical evacuation. And then if you have sufficiently evacuated the pus, then giving antibiotics after the evacuation of pus should prevent their reformation. So that is the principle of the surgery. So if you have done the correct evacuation of pus, then antibiotics alone is sufficient, and therefore you can do a primary wound closure. Now, why is this point coming here? To understand this point, I'll give you the difference between how a general surgeon treats an abscess as compared to how an orthopedic surgeon treats a osteomyelitis. So when a general surgeon is faced with an abscess, like a breast abscess or a gluteal abscess, basically the general surgeon is incising and draining the abscess. The wound is kept open, and once all the pus comes out, automatically the wound closes by itself and heals with secondary intention. However, if you have gone into the limb, and if you have opened up the bone, and if you have done the subperiosteal abscess evacuation, and after that if you have actually opened the cortex and evacuated pus from the metaphysis, then we are not going to keep the limb open, because if we keep the limb open, then obviously the bone is going to get exposed to the atmosphere and desiccate and die. And therefore, an orthopedic surgeon, after drainage of an acute osteomyelitis, is supposed to close the wound by a primary wound closure. So that is what it means. So the criteria says that in case you are able to effectively decompress the bone and remove the pus, then you can rely on your antibiotics to prevent the reformation of pus, and therefore you can close the primary wound. So that is the meaning of this NATES criteria. Now, one more important thing is, whatever surgery we do in the metaphysis, we should be careful not to damage any more bone or any more soft tissue, and especially we should be very, very careful that the physis is extremely close to this area, and the physis should not be damaged as far as when it comes to the treatment of the acute osteomyelitis. So this is something that surgeons have to take care, and obviously the criteria also suggests that the antibiotics should be continued after the surgery until the clinician is completely satisfied that the infection is very effectively taken care of and the body's immune response has started acting. So these are the guiding principles. So you will understand these principles a little more better when I actually guide you through the management of a patient with acute osteomyelitis. So now what do you do? Now initially you did the initial management and you image the patient. Now when you are imaging, very, very rarely you are going to find that the patient has come so early to the hospital that there is no abscess. So the abscess has still not formed. In such a patient, you are going to continue the antibiotics. However, you should also remember that this is an exception to the rule. Normally, the abscess should have formed by the time we image. So since this is an exception to the rule, we need to do a close clinical monitoring of these children and clearly keep monitoring their CRP levels. If the CRP levels are rising, that means the things are not working well. So the patient requires an evacuation. That's what it means. If the CRP levels are falling, that means the patient is responding to the antibiotic treatment that we are giving. Apart from CRP, we are also going to monitor the patient clinically for reduction in the edema and the child feeling better, the reduction in the spikes of fever and things like that. Whatever we do, we are not going to continue this treatment because this is a dangerous treatment for anything more than 24 to 48 hours. So why? Because in case we feel after 48 hours or 24 hours the child is not improving or the child is worsening, we are straightly going to move into surgery, because surgery is the rule of the treatment. So this no abscess situation is a very rarely that we find a child who is presented so early that there is no abscess. So in general, there is going to be an abscess on imaging, or there is going to be no response to antibiotics. So if there is an absence of imaging, which is the most common thing that we see, then the first thing that I want to do is I want to take up the patient for the surgery. So what is the surgical procedure we are going to do? The surgical procedure we are going to do is a few steps. The first step is I want to decompress the subperiosteal abscess. So I clearly showed you that in the subperiosteal area we have an abscess. So the subperiosteal abscess is going to be decompressed. So we are going to go there, go to the periosteum, to incise the periosteum and release all the pus from the periosteum, under the periosteum. So this is going to reduce the pressure under the periosteum and this is going to reduce further stripping of periosteum. As we are doing this surgery, we have to ourselves take care that we don't strip much of periosteum. That obviously comes with a little more experience. As we go on doing more number of cases, we'll be more skilled enough to ensure that our iatrogenic trauma to the periosteum is less as compared to the trauma that's already created due to the acute osteomyelitis. After decompressing the periosteum, next we want to decompress the medullary canal. So we want to remove the, obviously the pus didn't come under the periosteum from nowhere. The pus has come from the metaphysis. So whenever we see the subperiosteal abscess, we know that there is also pus hiding in the metaphysis. Again, at the end of the surgery, if we close the child back, what would happen is the same pus from the metaphysis would once again come and start lodging in the subperiosteal area. And therefore now we want to get into the metaphysis. Now how do you get into the metaphysis? You will obviously have to drill holes into the metaphysis. So what we do is we drill a few holes, and we will, when we drill these holes, we'll slowly start seeing this pus gushing out of the metaphysis. And then what we do is we actually connect the holes and create something called a cortical window, a rectangular cortical window. I'll show you the pictures for all of those. At this stage, I just want you to understand the steps. So the first thing is decompression of the subperiosteal abscess. Second thing is decompression of the medullary canal by creating a cortical window, which is usually rectangular shaped cortical window. Third thing is, once we have created a cortical window, we are going to scoop out all the pus from the metaphyseal area, taking care to ensure that our scoop does not go in and damage the growth plate or the physis. That's very important. And finally, after we are satisfied with all those things, we are going to close the wound over a drain. So any further accumulation of pus is going to come out of the drain. And also obviously we are going to give intravenous antibiotics, by which time our culture report, our blood culture report or our pus culture report is also going to exactly tell us which is the organism and which is the antibiotic that is most appropriate for this child. So what I'll do is I'll show you a few pictures, and this is my own case of a 7 to 8 year old child who presented to me with distal tibia osteomyelitis. So basically, for your reference, this is the ankle. So you can see that neatly, you can see the lateral malleus here. This is the medial malleus, and this is the foot which has been covered. And going above proximally is the knee, and this is basically somewhere the ankle joint is somewhere here, and this is the infection in the lower part of the tibia. Now there are two ways of actually decompressing this area. One, you can actually go medially, but unfortunately the medially right into the skin there is a bone. So if you decompress the child medially on this side, then post-operatively there is going to be a lot of scarring and adherent scar to the bone. So therefore we want to go anterolaterally. So what happens when you go anterolaterally, we have these beautiful anterolateral muscles here, and once we do the decompression, these muscles are itself going to go back and fall on this area and cause less scarring between the skin and subcutaneous tissue and the bone. So what we chose to do is we chose to go anterolaterally. So as you see, as we just go inside itself, so basically here you can see the congested periosteum with a lot of pus underneath the periosteum. So the periosteum is just bulging out from the bone, and then the periosteum is incised and the pus is removed. So this periosteum is incised and the pus is taken out. Once the periosteum is incised and the pus is taken out, then the cortical bone can be clearly seen. Now what we do with this cortical bone is we drill these holes, and as we are drilling these holes itself, the pus will start gushing out. Now then what we do is we actually connect all these holes together to form some kind of a rectangular window. So why is it a rectangular window? We want it to be not very broad. We want to be only 1/3 of the breadth. So the breadth should be not more than 1/3 of the breadth of the bone in that area. So obviously the breadth is going to be less. However, the length can be twice the breadth. So that makes it a rectangle. And by having longer length, what we can do is we can get a lot of area of the metaphysis which we can scoop out. So that is the concept. But if we have less length, then we will be able to scoop out the pus from only a small area of the metaphysis. Ultimately, this is surgery, and when you do surgery, the work has to be complete. So that is the concept here. This is the cortical window, and our cortical window has been created and the metaphysis has been nicely scooped up, and we are obviously giving a nice thorough wash in that area. So once that is done, the wound is closed over a drain. We put a drain and close the wound. Now this is one more case treated in my unit by my colleagues. So this is a very small child around 2 years of age who presented to us with a massively swollen humerus. This was a humerus osteomyelitis. So as soon as my colleague just went inside and elevated the muscles, immediately pus started gushing out because the pus had already tracked through the subperiosteal space, and though it's a metaphyseal infection to begin with, the pus had almost literally tracked through the entire shaft of the humerus in this child, and therefore there was plenty of pus and the pus started gushing out, and we were able to do a thorough evacuation, washing of that area. We did a metaphyseal cortical window, scooped up the pus from the metaphysis and then closed the wound over a drain. And also the child presented to us, when the child presented to us, the child was extremely sick, as just a small 2-year-old child. At the end of surgery, 24 hours into the surgery, we realized the child was absolutely normal, totally recovered from the pain, from the dehydration, swelling, fever, everything subsided, and the child made a quick recovery. Now, what is the further treatment? So further, there are two treatments. One is, of course, you're going to keep the child in the hospital for some days, and then you're going to discharge the child. So what is the further inpatient treatment? So further what you do is you're going to continue the antibiotics, whatever antibiotics the culture report has told us. You are going to continue to keep the limb splinted. It's very, very important. The limb has to be splinted with the help of a support. That is because now you have a double problem. One is the infection has already weakened the bone and made the bone susceptible to fractures. The other important thing is we have created a cortical window, and if our techniques are not right in making the cortical window itself is going to be a site of fracture for the child. So therefore it is very, very important that we keep the limb splintered, and once the child is clinically better, we can immediately convert the child from parenteral antibiotics to oral antibiotics. So previously when I was a student, we were being taught that we have to give 3 weeks of parenteral or intravenous antibiotics followed by 3 weeks of oral antibiotics. So we used to keep the children in this hospital for nearly 3 weeks. But now that's all changed. Now as soon as the child is able to take orally, we can give oral antibiotics. So studies have clearly proved that there is no difference into keeping parenteral. We can immediately convert the child into oral. Obviously, we are going to monitor the child with C-reactive protein, and as I mentioned, we are not going to monitor the progress with ESR because ESR is a delayed phenomenon, the rise of ESR. And when we feel it's appropriate to discharge the child, we are going to discharge the child with oral antibiotics with clear instruction to continue the antibiotics up to 6 weeks. Now what happens is, normally at whatever stage we discharge the child, we prefer to regularly keep seeing the child every 2 weeks up to 6 weeks. So that's very important. So every 2 weeks the child comes to us, we open the splint, we look for the healing of the surgical incision, and we put back the splint and we send back the child, also ensuring, talking to the parents, emphasizing to the parents that it's very important to continue antibiotics. Now here is a slight difference that we face as an orthopedic surgeon. Normally what happens is, what are the common infections children have? They either have a sore throat or an ear infection or a skin infection. Normally the antibiotic period is for 4 to 5 days or maximum 1 week. So here is a condition where we are actually expecting the child to take antibiotics for 6 weeks. The other important thing is, at the end of 2 weeks, the child is relatively fine. The child and the parents both would wonder, initially of course the child would start wondering, what sort of doctors are these? These guys have kept my limb splintered when I'm feeling much better. Later on, maybe after a week or so, even the parents also will start wondering, what kind of doctors are these? They kept my child splintered and they're giving the child antibiotics for 6 weeks when the child is perfectly normal. By the 3rd week, the child is almost perfectly normal. But this is where it becomes very important that we repeatedly keep calling these children and getting them back to us to keep emphasizing to them about continuing the splint as well as about continuing the antibiotics. That's very important. That's because effective treatment only will help us to eradicate the infection. The other thing that I want to emphasize is that the limb has to be splintered for up to 6 weeks, especially in weight-bearing limb. Now, weight-bearing bones. Now, at 6 weeks, we are going to check the ESR of the patient, and if the ESR has come back to normal, we are going to make a decision to stop the treatment. However, if the ESR is not come back to normal, then we can actually continue antibiotics for 3 weeks at a time and continue to monitor the ESR until it comes back to normal. Along with the monitoring of the ESR, we are also looking at the clinical and radiological signs of any pathological fractures that are developing in the bone. So that's also the other monitoring. So in general, it is only 6 weeks of treatment, 6 weeks of antibiotics, 6 weeks of splinting, and only occasionally a child whose ESR is not normal at 6 weeks, we go on adding every 3 weeks. Up to 12 weeks, we can give antibiotics. Now, most important thing is we have to clearly emphasize to the child as well as to the parents about the importance of splinting. And in weight-bearing bones, that like in the lower limb bones, we like to keep the child strictly splinted for 6 weeks. And after 6 weeks, we can allow the child to wear a brace, but we need to still keep the child non-weight bearing because there is a high chance of pathological fracture in weight bearing bones like the tibia and the femur, less so in the fibula. However, in non-weight bearing bones like in upper limb bone, like in the humerus and the radius and all, we can do the strict splinting for 4 weeks, and after that we can tell the child, we can give a brace to the child, but we have to avoid the child from loading the limb. That is to lift weights, lift school bags and things like that. So obviously strict counseling of parents and strict counseling of children is required to avoid a pathological fracture. I cannot emphasize less on splinting because splinting is as important as the antibiotic and the surgery. So that is why I am emphasizing so much on splinting. The other thing is the importance of eradicating the infection. What we need to understand is 90% or 95% of chronic osteomyelitis is because of inadequate treatment of acute osteomyelitis. So you ask the parents, do you want your child to go into chronic osteomyelitis of the tibia or of the femur? If the answer is no, then the infection that you have now, that is the acute osteomyelitis, has to be completely eradicated. And who is going to decide whether the infection is eradicated? It is not the parent or the child. It is the clinician who is going to define or determine that the infection is eradicated. Obviously, it would be based on clinical judgment, radiological features, and the fact that the child has completed a minimum of 6 weeks of antibiotics. So that again requires strict counseling of the parents and monitoring by the clinician. So this is where I told that I like to get the child coming back to me to the OPD every 2 weeks till the 6th week, so that I can repeatedly emphasize to the child and the parents about the importance of eradicating the infection. Now coming to the complications. So I told you the most common reason for chronic osteomyelitis is inadequate treatment of acute osteomyelitis. So here you see a picture of a radius osteomyelitis which is now moved into or now progressing into a chronic osteomyelitis. So this is one of the cases that was referred to us from the periphery, where the treatment for the acute osteomyelitis was inadequate, and therefore now by the time the child came to us with a diffuse swelling of the forearm. You can clearly see the soft tissue swelling here, and with a completely osteomyelitic radius. This is again a proximal tibia osteomyelitis that is now progressing into chronic osteomyelitis. Now the next important problem is damage to the physis. So damage to the physis can occur because of infection. I told you clearly in the beginning that the infection will not erode through the physis. Physis has got a very complex structure, it is cartilaginous, and I told you in the beginning that the infection will not erode the physis to go to the epiphysis. That is in the acute phase. But if you don't treat the infection immediately or promptly, the infection is obviously going to erode through the physis and is going to damage the physis. When it damages the physis, what is it going to do? It is going to cause permanent changes in the physis where it's going to cause something like calcification. So that's called a bony bar. So there is a calcification within the physis that can occur. And if the physis is calcified or the physis is damaged in a long bone, what do you expect? The physis is the growing part of the bone, and therefore you can either expect a growth retardation where that limb or that bone will be shorter than the other side, causing a limb length discrepancy, or sometimes a part of the physis is involved and therefore you can expect an angular deformity. So here is a picture of a patient who basically actually has a distal femur infection, distal femur metaphyseal infection, now presenting. That this is previously when the child had the infection, and now the patient is clearly presenting with a angular deformity. That is because the medial side is relatively okay, the medial side is growing normally, but the lateral side, the physis also is involved, and therefore there is an infection and therefore a deformity. And these angular deformities do present especially in adolescence because of the rapid growth spurt that we see in adolescence. Sometimes, very rarely, instead of damaging the physis, the infection can increase the vascularity in the physis, and by some strange phenomenon can cause growth stimulation. So what will growth stimulation do? The growth stimulation will end up elongating the bone. Of course, this is very rare, but when it happens, now you have an elongated bone as compared to the normal bone on the other side. In the upper limb, it should not be much of a problem, but in the lower limb, such an elongated bone is definitely going to cause a limb length discrepancy. Again, a problem. Now, so therefore, all children are expected to have limb length discrepancy or angular discrepancy unless proved otherwise, and therefore all the children need to be followed up to skeletal maturity. This is again one more important thing that we always emphasize to the parents, that just because you had an infection everything is settled. Please do keep in touch with us. Kindly show the child once every 6 months or once a year. So I prefer to see children once a year after the infection is eradicated, so that should be sufficient enough for us to pick up the emergence of a limb length discrepancy or an angular deformity. Now, as I mentioned to you, in the hip joint, in the shoulder joint and in the ankle joint, the infection in the metaphysis can progress into the joint because of the capsular connection that is taken in a part of the metaphysis and create a infection of the joint. So this is possible in the hip, shoulder and ankle joints. So progression to septic arthritis is one more complication, and progression to avascular necrosis, this can happen again in the hip joint and the shoulder joint because of the connection between the metaphysis and the epiphysis in children below 18 months. And the most devastating complication that I find it very difficult to manage is pathological fractures. So this is a distal femur osteomyelitis that was treated, and then of course, as you can see, it's a very small child. It's very difficult to keep these small kiddos in bed or splint them and keep, and then now the children now present with pathological fractures. These fractures, provided the infection is well taken care of, these fractures will readily heal. It is not at all a problem. But the problem is they heal with some kind of deformity. So those deformities are very, very difficult to manage, and therefore this creates a lot of problems for us. So these are some of the complications of acute osteomyelitis. As you can see, not just the condition is devastating, even the complications are also very devastating. And you should understand that these are devastating because these are occurring in a growing child. That is one thing. The other thing is it's also a big drag on the family, the rest of the family, the caregivers, the parents and all those things. So that is what I wanted to emphasize about the importance of prompt recognition and prompt treatment and taking all the measures to ensure prevention of complications of acute osteomyelitis. So with this, we come to the end of the class. Thank you all for your kind attention.